and I'm very happy to present the next speakers because, as I mentioned in the beginning of this session, I'm a local politician in the Stockholm County Council. Unfortunately, my party is part of the opposition here in Stockholms läns landsting. However, when it comes to ME/CFS and especially this part of Stockholm local healthcare that we will hear about, there is a total agreement, I would say, across political borders. So that's a good thing to build things on, I think, for this patient category. So the next presentation is given by Lena Nilsson, manager of the Neurological Rehab Clinic, and Ulla Lindbom, neurologist at StoraSko, Stockholm. And they will give a presentation of the newly opened ME/CFS clinic at the Stora Sköndal Foundation. So please, and give her a warm hand. Yeah.
Thank you. First of all, I'd like to thank the organizers for giving me the opportunity to present this newly opened ME Center at Stora Sköndal. There's a little change in the program. Unfortunately, you're stuck with me as a speaker, but Ulla is in the audience, and if you want to talk to her, you can do that afterwards. But what is Stora Sköndal? And what are we supposed to do according to the agreement with Stockholm County Council? You might want to know something about our thoughts and plans of research cooperation, and I will speak just very shortly about that. But also, as we have received a lot of questions, and as this is something that we really want to share with you, what is our view on rehabilitation and its place in ME care? Stora Sköndal is a foundation. It's quite old, but in constant change. It's an idea-driven non-profit organization with several branches. Currently, it comprises a neurological clinic, neurological rehabilitation clinic, a social psychiatry ward, geriatric care and nursing homes. We have accommodation for child refugees and also for asylum-seeking refugees. We have senior housing, a preschool, day care centers are open this year, and also daily occupation for people with brain injuries. Quite often people mix us up with Ersta, and that is true only, we are connected only in a separate organization, which is the Ersta Sköndal Academy, where education for nurses and sociologists and also a lot of research, especially in nursing and voluntary social work, is performed. But where on earth is Stora Sköndal? What you can see here is, if I can do that, no? Längst fram med den. Okay. Here you can see Stockholm City, and this is the globe, Ericsson globe. And this area is Stora Sköndal. And the yellow arrow here marks the Neurological Rehabilitation Clinic where the ME Center is located. And Stora Sköndal is just at the shores of Lake Dreviken, which is a very nice lake to swim in summer and very popular to skate on in winter. If we take a little closer look, I had to show you the original mansion, which is said to be the hunting lodge of Queen Christina, one of the many that she had in the 17th century. And this is the Neurological Rehabilitation Clinic in the first 2 floors here, and the ME ward. And this is our entrance and reception. The Rehabilitation Clinic has been existing since 1977. We have inward care for currently 28 beds, and receive our patients mainly from the large hospitals in Stockholm. We treat stroke, brain tumors, traumatic brain injuries, and also illnesses like Parkinson's, MS, and so on. Since 1990, we have a day ward rehabilitation, currently with 3 teams, receiving about 16 to sometimes up to 25 patients a day, who live at home and come for treatment a couple of days a week. We have also a speech therapy center, apart from the others, and a physiotherapy center. And this summer, we opened the ME CFS Outpatient Center with specialist doctors and also a rehabilitation team. And here are some pictures from our newly renovated place. This is the waiting room. And here's a room where you can lie down before or after or even during the doctor's visit if you need to. And here's a room where we have small meetings. And this is the team. Our physiotherapist is not on the picture because she was taking it, but I'd like to introduce them to you so you know who they are and you can speak to them afterwards. Ingegerd Lövgren, our physiotherapist. Eva Wadhagen Wedlund, occupational therapist. Jessica Lundblad, our nurse. Anders Eld, neuropsychiatrist. And Mia, förlåt? Ursäkta. Sorry. And Mia Fremberg, social worker. And our doctors, Per Julin and Ulla Lindbom, specialists in rehabilitation medicine and neurology. So, we work under an agreement with the Stockholm County Council to provide assessment and treatment for patients with ME CFS in an outpatient setting. As it says in this agreement, the care should be characterized by high quality, being easy to reach, health promoting, and professional in terms of personal treatment and care. Cooperation in scientific research is prioritized, and we shall provide care and support for patients in all ages with ME CFS, and we should use the Canada criteria. It includes completing diagnostic work if the diagnosis is unclear or if it's in need of reassessment. And we should care for patients with severe and moderately severe ME CFS and for patients in need for team-based rehabilitation. We interpret that as if you are in need of team-based rehabilitation, you can have ME that is not necessarily severe. The mission does not include patients with conditions of acute tiredness and fatigue or patients where investigations and treatment can be performed in primary care, of course. This agreement is in line with the outpatient's right to choose healthcare provider. That is, you can come from other parts of the country. And the rules about referral are as follows. All patients, all children, all patients under 18 years of age should be referred from pediatric clinic after medical assessment there. Adults from some counties, currently Jämtland, Härjedalen, Dalarna, and perhaps Västmanland, I think they are about to change it, and Örebro until the beginning of 2016, must be referred by a physician. But adults from other regions, including Stockholm, referral from physician is not mandatory, but it is desirable. And in all cases, we need a medical basis for decision, that is a fairly thorough, written medical history and access to results from investigations already made, and this is because we have a very large amount of referrals already, and we have to speed up the work. Now, at your first visit, you meet the nurse and your doctor for interview and examination. There may be some additional blood tests, and you also discuss with the doctor if you would benefit from contact with the rehabilitation team. In a following discussion where all team members, including of course the doctor and nurse, is present, a plan for what is going to happen next is made. Either the contact continues with only doctor's appointments, or you come to see one or two or all of the team professionals in the rehabilitation team. But when this period of orientation is over, a second discussion summarizes the process so far, and at your second visit to the doctor, this is discussed with you, and you decide together how the following process should be designed. So you can continue to have only contact with the doctor and the nurse. In most cases, this will not be very frequent. Or you can start a series of treatment sessions with the professionals that you need, and also according to what you can cope with. These consultations can start at any time during your contact with us, even after many months. We do not yet have any group rehab programs, but we plan to organize that in the future, probably, hopefully, starting already early next year. Now, if you come from other counties than Stockholm and you have to travel to get to us, we try to make all these starting consultations in just 1 or 2 days, and then do most of the follow-up by telephone to avoid too much traveling and exhaustion according to that. I said that I would mention something about research plans, but Per and Ulla are the ones to talk to if you want to know more. But we have started collaborations with Karolinska Institute. Together with the departments of radiology and IMR physics, we plan to assess new magnetic resonance imaging markers for neuroinflammation and brain function in patients with ME. And we have a collaboration with Karolinska PET Center, planning to help recruit patients to an ongoing study on PET markers for neuroinflammation. We also plan to do a study together with Professor Blomberg in Uppsala University regarding virology, bacteriology, and autoimmunity. So I will not say anything more about this, but we hope to be able to present more about these plans during the spring 2016. As I mentioned earlier, we have received quite a lot of questions about what kind of rehabilitation we will offer. But as a neurologist, I also know that the knowledge of rehabilitation is generally low, also among healthcare professionals that, despite highly educated and specialized, if they do not work directly in rehabilitation. So we thought it was important to elaborate on this subject and to give you our view of the nature and the good of rehabilitation. The word rehabilitatio means recreate or regaining function or dignity, but perhaps we can need a little more detailed definition. The WHO and the World Bank made this definition in the World Report on Disability in 2011. Rehabilitation is a set of measures that assist individuals who experience or are likely to experience disability to achieve and maintain optimal function in interaction with their environment. With a little interpretation, it tells us essentials in the concept of rehabilitation, and I would like to take you through it. Rehabilitation is a set of measures that assist individuals. This points at the patient as a subject, taking responsibility, at assessing the individual's resources and possibilities as well as problems and difficulties, and that we always make individualized rehabilitation plans. That assist individuals to achieve and maintain optimal function, that is, to achieve improvement and maintaining it, or to maintain function despite a progressive disease. To achieve and maintain optimal function, you know that the conceptual basis for rehabilitation is the ICF, the International Classification of Functioning, elaborated by WHO. And this tells us that the same diagnosis can mean totally different consequences for different individuals in terms of body function, body structure, activity performance, and participation in the person's social context and in society. But also that environmental factors and personality factors influence the consequences and must be taken into account. To achieve and maintain optimal function in interaction with their environment. This tells us, of course, about facilitating techniques such as the use of wheelchairs and other tools and cognitive strategies. But it also reminds me of the interaction between the patient and the healthcare provider. You probably know that in rehabilitation, teamwork is essential. As we see it, teamwork can be seen as a continuum on varying degrees of integration, from the multidisciplinary team in which team members work parallel and communicates, perhaps mainly by sending notes to each other, to the interdisciplinary team, where the professionals work in close cooperation with each other and with the patient towards shared goals, and with a high level of integration and communication. So now you know everything about what rehabilitation is, and we can summarize that in another definition. Rehabilitation is a process where a person, most often with the guidance of a multi-professional team, through training and compensation techniques, obtains changes in oneself and in the environment in order to fulfill old and new goals in life. The treatment process comprises not only interventions regarding body functions, but also aspects of activity and participation in the person's social context and in society. But how does all this relate to the person with ME? If we look at ME from an ICF point of view, we can see that ME is a condition with consequences that can be complex, but that vary greatly from person to person. In body function, we recognize variations in the severity of fatigue. We see individual variations in impaired functions due to other symptoms of ME, such as pain, sleep disorders, and cognitive dysfunction. We see variations in psychological impact and also in comorbidity, other illnesses that may or may not be present. In activity and participation, we can see different situations in aspects of autonomy, in the ability to manage one's daily life, in family situation, in transport, for example, driving, working capacity and employment, of course, leisure activities and social life, and perhaps also the feeling of stigma. But all of these consequences can in different ways be addressed in rehabilitation. But what makes us believe that we can make a difference by providing rehabilitation for persons with ME? The background is that this team at Stora Sköndal has been, since more than 20 years, been building rehabilitation programs for groups and individuals and performing neurological rehabilitation also for chronic conditions like life changes after stroke and chronic illnesses like for example, epilepsy and Huntington's disease. Our OT, Eva Vardagen, has performed a follow-up study of our now more than 200 patients that have gone through the special epilepsy rehabilitation program. And she also did investigated the patient's experience of rehabilitation by discussing in focus group interviews the question, what has been most important in rehabilitation? And our patients stated the importance of the rehabilitation being individualized to its intensity, its duration, and its content. That is, that it was based on the individual's problems and resources. They also talked about the importance of meeting other persons with epilepsy in small groups to share experiences, and of meeting a dedicated team with high epilepsy competence, but also that information and support was given also to family members, and to get support in emotional coping, and support in contacts with authorities and workplace. Just to finish, the ME CFS Center at Stora Sköndal has only just started. But we intend to build it on our experience of neurological illness and impairments, and of learning from our patients. We intend to provide long-term support and follow-up for persons with ME. And we know that rehabilitation to enhance the quality of life is never too late. We hope to be able to contribute to the development of knowledge and treatment measures. But we also think that until a fully functioning remedy is available, we need to work together to enhance the consciousness of ME being a public health condition, which the person manages every day, like, for example, persons with diabetes or Parkinson's disease, where education and guidance and rehabilitation is a natural part of healthcare. Thank you very much.
Thank you so much, Dr. Lena Nilsson from Stora Sköndal. As you said, you have recently just started, and I think that was a very informative presentation from that point of view, anyway. So, again, as one of the politicians that across political borders decided to start this elective care, I'm very glad to have it started again. So good luck with your important work. And with that said, I open the floor again for perhaps one or two short questions before we collect everyone on stage here. Sure. Dr. Ian Gibson.
Who pays for it?
Who pays for it?
Stockholm County Council.
Some taxes, does it?
Yes.
Yeah.
Okay. Entirely.
Yes.
Entirely, yes.
Pretty good.
Yes, it is.
Not many countries do that.
Well, there's a small, relatively small patient fee, of course, but... Okay. More questions? Do we have, again, a mobile microphone?
It's a short one.
Well, we want to have this on film, you know, so...
The question was about how long do you have to wait to get us? I have to say that until now we have received more than 400 referrals. And we are, you see 2 doctors, but they are not working full-time now, perhaps soon, but I don't know. So you have to be patient. You know, we didn't know. This is open to all clinics that have specialized neurological rehabilitation, or for neurological diseases or for pain, but it was only us that started. So we didn't know from the beginning what dimensions should we have. So this is what we have started with. Yep.
Sounds like a challenge. We had one more question in the middle here, and then I think perhaps we start gathering all the speakers. Okay.
Yes, I was wondering, is there anything you can do by yourself to speed up the process, like writing the medical history or sending it to you to reduce your workload and speed it up?
We need for everyone, we need a medical history. The best thing is if you can, if you have a doctor that can summarize it. Otherwise, you collect your data yourself. We need it, because if we don't get it, we have to send it back and say, you have to do that.
Okay.
Okay, one more in the middle there.
Yeah, thank you. As I understood that you mainly focus on rehabilitation, but do you use any medical treatment? For example, Dr. Peterson mentioned earlier today that there are some drugs available actually that can be used.
I must say, we don't mainly focus on rehabilitation, but this talk was to explain to you how we see rehabilitation. But according to medical issues, this is a outpatient clinic for doctors' appointments, and hopefully Per can answer a little about medical.
So far, what's new to me, this data about treatment that really could affect, because a disease-modifying treatment that were approved in Europe, so we of course have to change that. Otherwise, it's mostly about symptomatic treatment for sleep problems, pain, and so on, which is available so far.
Okay, thank you.